As more people with CF are living beyond the age of 50, new challenges arise. Comorbidities such as osteoporosis, colorectal cancer, hypertension, and arthritis generally start to emerge as people surpass 50. Today, we're talking to Dr. Victor Roggli, a 74-year-old with CF who also is a researcher in pulmonary pathology. And we are welcoming back John Kleven, who you might remember from episode 1 when we talked about IVF. A little later, we will welcome in Dr. John Lindsey, a faculty member at UC San Francisco who specializes in male fertility, hormonal function, and sexual health. All three of us will get answers from Dr. Lindsey to the questions we're bold enough to ask. Thanks for tuning in. You're listening to Bold Enough to Ask, a Breathe Strong CF podcast that tackles questions for people with cystic fibrosis. Breathe Strong CF empowers the cystic fibrosis community to thrive, not just survive. I am your host, Chad Bautch, a dad living and thriving with CF and an advocate for the CF community. This first season of Bold Enough to Ask is going to focus on the questions men with CF have around sexual and reproductive health. Well, welcome, gentlemen. Thank you very much for joining us today. Appreciate you guys taking time out of your busy day. So we're going to jump in. I've got a lot that we want to address today. This episode, as we know, we're talking about sexual and reproductive health in men over 50 and the aging process and everything else that comes along with it. A cool factor now for CF patients is that we have to start looking at what happens as we're getting older. We're now just as susceptible to the aging process as everybody else. So it's been a fun learning bit. So we're going to start with you, John Kleven. Tell us a little bit about yourself, how old you are, and kind of what brought you here today to this podcast.
Thanks, Chad. So I am turning 52 in April, and I'm a late diagnosis, cystic fibrosis. And I feel like a lot of this is new to me still, compared to people that have been diagnosed at birth or at a young age. And so it's great to see people like yourself and Victor and others that are of the same generation as myself that are older, and the things that they're doing to make sure that they're going to live a long life.
Yeah, I like that. So as somebody who was diagnosed at birth, yeah, it's something I've lived with my whole life and known about it. Same with Dr. Victor Roggli, but as a late diagnosis, I'm sure a lot of this is new. And so learning as you're going is kind of a big deal. Dr. Victor Roggli, tell me a little bit about what it was like. First of all, tell us about when you were diagnosed, because I know I mentioned this already, but you're the oldest living CF person I've ever met at 74. And so tell me just a little bit about what it was like when you got diagnosed, and now kind of a later life CF, or what life is like now compared to when you were younger.
Yeah, I did pretty well up until I was about 7 years old. I'm currently 74, so I was born in 1951. And when I was 7 years old, I got sick with working out in the cornfield and had mumps, measles, double pneumonia really quickly over a short period of time. And from that time on, I had a chronic cough and ate my parents out of house and home, didn't gain weight. When I was about 10, my parents in desperation took me to see an allergist who sent a letter to my hometown doctor recommending I have a sweat test. It was never acted upon, unfortunately. So finally, in desperation, my parents took me to Vanderbilt when I was age 12. And the pulmonary fellow that I saw there immediately recognized the symptoms and all the complaints that I had as being highly likely to be cystic fibrosis. So he recommended a sweat test. And so at age 12, I was diagnosed with the sweat test, and uh, the doctors then gave me medications which helped with the digestion and absorption of food. And over a 2-year period from age 12 to 14, I doubled my weight from 70 pounds to 140 pounds.
Wow, that's impressive.
So as a result of that, of course, my maturity lagged far behind my classmates, which became an issue for me as well. I think that's basically my story. I am a Delta F508 homozygote, which is what 70% of the patients with CF have that particular gene profile.
And tell me now, just as you've gotten older, what have some of the complications that you've come across to bring you here today to talk about this?
Well, of course, I had the chronic lung disease and been treated with all sorts of treatments for that, including occasional antibiotics that I'll have to take. And then I also developed heart disease as a complication of the lung disease, and was evaluated for a lung transplant in 2015, which it turned out I did not do. And then in 2017, they started me on a new medication, which was the small molecules which help the CFTR gene do what it's supposed to do.
Mm.
And then that stabilized me for a while. And then in December 2019, I got on Trikafta, which made a huge difference. And as a result of that, it changed a lot of the treatments that I needed and all. So then when I hit about 71 years of age, I'd known for some period of time that I had a high prostate specific antigen, the PSA level. And that's in my family because my family, my father had it, my brother had it, chronic prostatitis, and they had uh, got treated with antibiotics, didn't help it. Then they got a needle biopsy, and it was just prostatitis, not cancer. So I was really reluctant to do anything about it, but my doctors finally convinced me that I should have a needle biopsy of the prostate, which I did, and it showed cancer to be present.
Mm.
So, starting at age around, it was either 71 or 72, I got treated with radiation therapy and with an anti-testosterone medication, which I took for, it's an oral pill, which I took for 18 months. And after that, discontinued that, testosterone levels have not come back. And so that's one of the main reasons I'm here today to talk about some of those issues.
That's great. So, that's an amazing, like, just from diagnosis all the way, and now we have so many different comorbidities now, it feels like. So, as we age, obviously, they're gonna continue to grow and get bigger. Tell me about what was it like for you, Victor, to start that kind of conversation? You had the family history, but what was that like to start a conversation with a urologist? When did that start for you? How often are you following up with people? Talk us a little bit through about what it's been like since the diagnosis of the prostate cancer.
Well, I think in 2015, the PSA I had measured was up, and my doctors had mentioned about it. Should I do something about it? But I said, no, this is in my family history. But then by 2020, somewhere around in there, my doctors noticed this is going up. Continue, it was a little bit too high. So I said, okay, I'll do it. I mean, I'm a physician myself, so if my physician urologist say you need to have this done, I wasn't going to argue with them about it, and they did it, and it was turned out it was a fairly low grade variant of the cancer, but some of the X-rays that they took, the MRI showed that there may have been a high grade focus, which is why they wanted to go ahead and treat me with the radiation and the anti-testosterone. So since they did that, some of the issues I've had have been problems with sexual desire and motivation, and also some depression as a result of that, and also weight gain. So all of those are associated with very low testosterone levels. And, in fact, I actually saw an endocrinologist yesterday
Mm.
or Friday, who recommended that I start taking, these, lotion that you can put on your shoulders once a day that will help with those issues. So finally, I'm gonna start getting treatment to, help relieve some of those symptoms that I mentioned.
I'm curious, did you when you were looking for an endocrinologist or even a urologist, did you seek out anybody specifically that had history with CF or at least a knowledge of how that affected the other aspects of your health?
No, and I have heard some lectures from individuals who are urologists who have dealt with CF patients and have talked about this testosterone issue. But my urologist, uh, there's a cancer center at Duke where I work, which is just 5 minute walk from my office at Duke. So I didn't have any problems going there and going getting the radiation treatment and getting seeing the medical oncologist and getting follow up with them, which I did over and still do follow up for the treatment of my disease, and so that went very well. I was very happy with the treatment that I got and with the doctors who did the treatment.
That's wonderful. Trusting your doctors is obviously that relationship is so vital, especially when you're seen by as many doctors as we are seen by. So that's great that you were able to have that relationship. John Kleven, question:
Yes.
where are you at with your health journey and aging and urologist and even like colon cancer screenings through the colonoscopies? Tell me a little bit about where you're at in that process, being a younger, 52-year-old here to be. So where are you at?
Well, my 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 pulmonary team and my primary care are in two different systems, and it's an interesting dynamic, and I don't know how much they talk. As a matter of fact, I was really sick this last spring and ended up in the emergency room, and um, I was going to go up to the one provider, and they said they didn't want to see me, and that they needed to hear from my pulmonary team, and so it was kind of this back and forth as I'm trying to figure out going to the emergency room, and so the same thing kind of goes for my primary care as well. Um, I don't know um, who called for the Cologuard um, test, but I've had 3 Cologuard tests that they just showed up at my house, and somehow, some way, insurance paid for it, and they come back negative. So I've had Cologuard and also skin cancer screening and PSA tests. So because of insurance, I uh, I go through the one provider, see my pulmonary team. I need to get the pre-authorization and all of that stuff. And then for the other provider, it's just kind of like an annual checkup.
So that brings up preventative care. So it sounds like, John Clevin, your preventative care is basically done through your primary care physician, which is great because you've got that existing relationship. But outside of that, and then your CF team, is it safe to say you don't have like a endocrine team? You haven't met with anybody from urology? You haven't done anything like that yet?
No, I met
Okay.
with somebody from urology with
Doing
for
the IVF.
during IVF, and that was 15 years ago, 16 years ago. So I don't have any connection with any urologists or anything like that.
So, Dr. Victor Roggli, I would love your thoughts on when, as an older CF patient, what would you recommend for younger CF? Like if you were talking to young people like John and myself, right at 50, what would you recommend us start doing, and maybe when would you recommend us start doing it? As both a physician, but also someone who is living with CF.
Well, the physician community, I think, is just beginning to realize that the CF population is getting older and has to have considerations for some of these geriatric issues. And that's becoming more and more prominent all the time. So it's very important to keep in touch with your CF treating doctors to ask them about doing that. And just one example that John talked about was the colon cancer issue. Colon cancer is recognized to be it's an increased risk if you have cystic fibrosis. For me, my father died of colon cancer at age 76,
Mm.
and my grandmother on the maternal side had colon cancer, which she was treated for. So I've already got a family history risk of that, independent of the cystic fibrosis. So I decided, well, 3 years before my dad was diagnosed, and when I get 72, I'll have a colonoscopy because if there's a cancer there, they'll get it early, they'll take care of it. And, they actually talked me into doing it at age 71 instead of at age 72. And they actually found a polyp in my cecum. That's the most proximal part of the colon, just right after the small intestine dumps into the colons where the cecum is. And, they found a large polyp there is almost 3/4 of an inch in size,
Mm.
and it already had some, non-invasive cancer cells involved with that polyp. And, they took it out, and sure, I mean, there's almost no doubt that if I'd waited till my dad's age of 75, I would have already had invasive and possibly non-resectable cancer at that point in time. So, it's good to have that. I've had follow-up colonoscopy since then and, had just some very small benign polyps present that they weren't worried about. So I think they're now have got me set up to do, an additional colonoscopy in 3 to 5 years, somewhere in that line. But getting those screening tests, which as John mentioned, the Cologuard can be very helpful because that's a relatively non-invasive thing that you can do that can warn of the possibility that you may need to get a colonoscopy. And then I think working out with your doctors to see what they recommend in terms of when you should have screening tests done for that disease.
Yeah. I'm not an expert by any means. My transplant was in 2016. My team recommended that I start getting screenings in 2017. I believe at the time I was like 45. I'd have to do the math on that. Um, but first colonoscopy, bam, colon cancer. So, um, I went through a surgery to remove it right away, and everything's been great ever since. But I do routinely go in now for every year because I'm a high risk person, and because of that previous diagnosis, Cologuard or those other types of tests are not applicable to me. I got to go in every time. So I definitely John, keep up with the Cologuard unless your CF team tells you go see somebody else for sure. That's interesting though that and I agree, coordinating everything through your CF team is critical because they're the ones that are most knowledgeable about our disease. And so as the rest, and it's not a negative thing, but as the rest of the physician community catches up to the CF knowledge that they have, now that we're all aging, just having that person that has a little bit of experience with us as well to coordinate that care with all across all the teams is going to be really important as we continue to grow older. So I want to save that for when we bring in Dr. Lindsey, but I want to hear your guys' thoughts on, do you guys feel like colon cancer screenings, just these different types of screenings, do you feel like that's part of sexual and reproductive health in general?
I haven't thought about that connection. I don't see an immediate connection except that both issues can be related to having the disease cystic fibrosis. And so they're important things to keep in mind as we get older because the issues as we get older, is it CF or is it aging, the issues that you're dealing with, or is it both together?
And I think too, when we think about like prostate cancer, for example, I mean, you mentioned it's driven your testosterone level down. You mentioned that it has affected your desire and for sexual activity in general. And now you're going on the testosterone cream. So I do think there's a tie in there between how it all our bodies are all interconnected and work together. It's just a matter of, like you said, is it CF related? Is it aging related? And if it's aging, does our CF play a part in that? And I think that's where we need to do some study because there hasn't been a ton of studies about that kind of stuff just because we haven't had the population to study on yet. So it's been interesting. The other thing I'd like to think about as far as we talk about as we age is just heart stuff. You know, people that live longer have greater risk of heart attacks. And so symptoms of a heart attack, tiredness, fatigue, shortness of breath, guess what? All that's related to CF too. When we have that's part of CF as well. So just trying to
Right.
decide, when do we go see a heart or cardiologist versus do we just need to check in with our CF team and see how we're doing?
Chad, that's one thing that I've thought about quite a bit too is those moments where you have fatigue or are really tired or feel like you've got to go lay down and I just feeling like, well, is that CF or is that me getting old or is that my heart or and I know that my primary care doctor and like my blood pressure and my cholesterol and everything like that are good, but then still I'm thinking, well, is it really good or is it CF or is it just getting older? And it creates that conundrum, kind of like what Victor was talking about, that uh, kind of digging into maybe still a little bit of anxiety or maybe a little depression, just thinking like, am I just doomed or is this part of aging? And that's why I think it's so valuable to have somebody like Victor and being able to talk to people that have lived with cystic fibrosis longer to kind of gauge that paradox.
Yeah. So John, go dig a little deeper for that for me. I know that you like to do a lot of non-medical type stuff
True.
to when you start to feel that way. So tell me a little bit about what you prefer. I mean, obviously you're under care of your physician, your CF docs, but what else do you like to do to try to help kind of balance some of the or counterbalance some of those effects, those symptoms?
Well, it's kind of like the what is it, the Rolling Stone gathers no moss mentality of movement, and for myself, I've noticed a lot of correlation between activity and tiredness or fatigue. Sometimes the fatigue will just come and hit, and I've got to take a break and go lay down. But I've also noticed that my daily regimen. So depending upon during the work week, I try to keep a very strict regimen of waking up, getting some hydration, adding some salts or some electrolytes to that, sitting in the hot tub to loosen up, because I feel like with all the coughing and all of that, it it tends to tighten up my back, and so then my back gets all tight, and then you don't feel like doing physical activity. So I jump in the hot tub and then try to do some type of stretch or some type of exercise, and I try to throughout the day then keep moving. After the stretch and the exercise, I try to read something spiritual, some type of devotion or some type of thing that gets my mind and my spirit awakened, so I can at least have an advantage to some of those negative thoughts that come in. And then, of course, in the morning, I do my vest therapies as well, and that's kind of that constant reminder of that it's a disease, and it's with you every day. And so I feel like the days where I'm moving a lot and the days that I'm active are the days that I typically don't have a struggle with depression or anxiety or those types of things. But it's the days like on the weekends, like today, where you push things a little bit. You think, oh, I've earned it this week, and so I can just relax, where it sneaks up on you. Even before this meeting with us today, I'd been lying around all morning, and I just totally skipped all of my regular routine. And I can already tell mentally, if it wasn't for meeting with you folks, which is bringing an uplift to my spirits. Right before this, I was thinking, I don't know what I'm going to just lay around more today. And so it's just getting that gumption of getting up and moving, or taking a walk in the woods, or lifting weights, or whatever it is that I feel like doing, and then mixing it up. So I'm not kind of stuck in this routine that gets boring. So I have something to look forward to. So I feel like when uh, the routine before work, if I keep that consistent, it's good. But if I mix up the stretching with other types of exercises, and then at work, make sure I get up and moving around, so I'm not sedentary, I feel like that really helps.
And talk to me a little bit too about how your diet affects how you feel, and then even with what you try to do for staying healthy.
What I eat, I'm feeling, it has always impacted me in a very intense way, and it sneaks up on me sometimes. Blood sugar or whatever it might be. So I try to get as much protein and vegetables and fruits as that I can. I right or wrong believe in uh, as much as possible, or organic and all natural diet as much as I can. And when I stray from that, I definitely feel more sluggish. I definitely feel more brain fog. I definitely feel um, spikes, probably in blood sugar. And I've noticed that when I do things like eat a donut or have a bagel or something like that my body's not used to, it throws me for a curve. I've noticed that what I eat or what I don't eat drastically impacts my health and my well-being. I'd really try to keep tuned in to what my body's telling me, and how I'm feeling, and my energy levels. And is as hard as it is to pry myself out of a chair to get moving, I, I know that I have the tools to do the things or consume the things that are helping me.
That's great. That gives me a great opportunity to bring in Dr. John Lindsey a little bit. Dr. Lindsey, thank you very much for joining us. A couple questions I want to start with you. John just talked to us about all of his dietary stuff and his theory on the exercise and just how that is a positive effect on both of his mental and physical health. It's no different in CF people probably than it is everybody else, and then the fact that maybe it's harder for us to be active. Talk to a little bit about how an active lifestyle can help us with our overall general sexual reproductive health in men.
Yeah, a great question. I think a couple domains come to mind initially. So, from a cardiovascular standpoint, we know that regular cardio workouts and weightlifting keeps your cardiovascular system healthy. Keeps your blood pressure levels in check, and it maintains the health of those tiny blood vessels, and that will protect sexual function, right? So an erection depends on tiny blood vessels, and that's why it's one of the kind of first things to go. And erectile dysfunction and can be a marker of pending cardiovascular demise, for lack of better words. So working out from that standpoint will maintain your capacity for erections. And then the other benefit is your hormone production. So we know that testosterone levels can improve with both weightlifting as well as cardiovascular exercise, and to the extent that it keeps you lean, keeps you fit, keeps your body fat percentage down. That also contributes to improved testosterone levels. Our fat cells convert a percentage of our testosterone into estrogen, and then that estrogen goes back and keeps your testosterone at certain levels. So working out is helpful in many aspects of our physiology.
So you brought up testosterone levels and how that all bolsters that. Talk to me a little bit about testosterone levels as far as CF people go. As we get old, as we get older, obviously across the board, testosterone levels fall. Is
Yes.
there a heavier correlation to CF males than
Yeah.
the general public? What's that like?
Yes. So, looking at just some of the statistics, the prevalence of low testosterone in the CF population is not well understood. Some studies estimate that screening for testosterone levels is only being done in about 10% of CF patients. So
Mm.
that's probably one of the biggest takeaways that I have for this discussion today is just talking to your primary care provider about checking your testosterone levels, because we know based on the prevalence estimates, low testosterone is anywhere between 28 and 43% of the CF population.
Mm.
So definitely something to talk with your team about regularly. And I think there's historically been a lot of controversy around testosterone therapy and understanding testosterone levels. I think that's why it's not part of routine screening presently, but it is something that I think we are gaining increasing awareness of. Actually, I'm on the testosterone guidelines for our National Urologic Society. So we're updating those guidelines in the next 2 years, and we just actually submitted a request for information to the FDA. So there's, I think, increasing awareness on the importance of testosterone and testosterone therapy.
Okay, so testosterone therapy. Dr. Victor just told us that he's started a lotion on the back of his shoulders. I have done that in the past as well. I've also gone through the injections. I've also actually had the pellets as well. So,
Hmm.
A, do you recommend hormone replacement therapy in people who are short in testosterone, obviously? But how does that affect, it doesn't at all affect anything CF related? Could that
Yeah.
cause issues with us?
Yes, yeah, great question. So, first part of that question, do I recommend testosterone therapy for patients with low testosterone? Absolutely. I treat many patients with low testosterone, and our current guidelines. I think both the Endocrine Society and the Urologic Society recommend anyone with a total testosterone of 300 nanograms per deciliter or lower should consider testosterone therapy. So it's a great therapy, and I'm always happy to see those patients back and the impact that it has on their quality of life. And then in the context of cystic fibrosis, I think that there's no evidence that it is detrimental to health. So if anything, it seems to be just as helpful in the CF population as it is for everyone.
That's great to hear.
And another important point there, so we know that testosterone levels, the prevalence of low testosterone is higher in the CF population. Uh, in a very, very important point, we're talking about fertility. So for the CF patient who maybe, age 17 or, in their 20s are diagnosed with low testosterone, super, super important to have that fertility discussion, which I know you guys probably discussed in the previous podcast, but starting testosterone therapy by itself, so we call it testosterone monotherapy, can suppress sperm production. So before starting testosterone, if fertility is something that is in your future, then there should be a discussion about how to manage that fertility before starting singular testosterone therapy.
So, Dr. Lindsey, in both of our previous, and John, I promise I'm going to come to you. In both of our previous podcasts, we talked about banking sperm. And so is that kind of what you're referring to here as well?
Yes, yeah, and in the CF population, often it's going to be sperm cryopreservation, and then that's one approach. So let's say you're 25, you have low testosterone, you're interested in starting testosterone therapy, but fertility is important for your future plans. The one approach would be to have sperm extracted from the testicle and have that frozen. There are also, options to consider extracting sperm if you have a partner and forming embryos, because we know that overall embryos preserve better than sperm. But both of those approaches are reasonable, but not absolutely necessary. And so you can start testosterone, or sometimes, depending on your physiology, there are medications that can boost your natural production of testosterone while maintaining your sperm production. So those are considerations.
Great. John, what did you want to ask?
That was very valuable. Thank you, Dr. Lindsey. I think that would be a good tie-in to the previous podcast. I agree. I was wondering also about Chad and Victor. I don't know if you all take vitamins or not, or the need for vitamins. That is one thing that I do add to my regimen every day, where I take a multivitamin and some fish oil and D3 with K2, and I take it religiously, and I spend a lot of money on vitamins, and just from what I've heard from my team about the ability to absorb nutrients and that kind of thing, and the importance of it. But it would be nice to hear from Dr. Lindsey and from Chad and Victor, just to kind of see like what are the best vitamins as we age, and what are the things that we should be taking, or maybe what are the things that just really don't have any statistical relevance.
So I think Dr. Richter is going to be much more adept on the vitamins. We do know that the fat soluble vitamins are often deficient in the cystic fibrosis population. So those are vitamins A, D, E, and K. And so supplementation with those may be indicated. I'll turn it over to Dr. Roggli.
Well, I just mentioned that, yeah, I do take it's a multivitamin supplement. It's 2 capsules in the morning, 2 capsules in the evening. I think it's DHS. The particular one they have for me, multivitamin, is with copper. Sometimes they have it with iron. So there's various ways you can do that, the multivitamin. And I also take the vitamin D. It's a fat soluble version, which you can spray 3 sprays in your mouth in the morning, and it also can help with the issues of bone degeneration, osteoporosis, which happens if you're lacking in vitamin D, and also something that's seen in patients with chronic lung disease. So that's a useful supplement that I do in addition to the multivitamin.
Is there a particular vitamin, if we're starting a testosterone regimen, is there anything that we should take to help our bodies kind of accept that testosterone better, or is there anything else? Is there anything we can do to help maintain those levels?
Yeah, it's a great question. I think when you think about like iron supplementation, for instance, sometimes vitamin C supplementation can be helpful there. For testosterone, the absorption is a little bit different, with it being a cholesterol-based hormone. It can pretty readily be taken up through topical therapies, which is typically like androgel. So that's absorbed well. To my knowledge, isn't very dependent on sort of vitamin supplementation. And then there are many other forms, as you were mentioning earlier, Chad. So there's intramuscular injection, in which patients do anywhere from twice weekly to every 2 weeks. and that is pretty effective. There are pellets that can be installed typically into the muscle of the buttocks. That's done roughly every 4 to 6 months for certain patients. There are oral formulations of testosterone which work well.
Sounds like there's a lot of things, and obviously consult with your treatment team before starting any of that stuff. But now I want to talk specifically, Dr. Lindsey, you're a urologist, and so
Mhm.
talk to us a little bit more about the role urology plays in our CF care. I know, for example, John was diagnosed with CF from a urologist because he was a late diagnosis as a result of
Mhm. Mhm.
infertility. So
Yeah.
just tell us a little bit about what that role looks like for a urologist and CF patients.
Yes, yeah. I think the earliest is going to be, as we just highlighted, with fertility, often, or even low testosterone or hypogonadism. That can be the earliest interface, and both of those things are pretty impactful for quality of life, right? For fertility and for testosterone levels. And then later in life, with prostate cancer screening, I think is probably the most important one. But testosterone continues to play a role, as you see. Prostate cancer treatment can also render someone hypogonadal after being on androgen deprivation therapy, and they changed quite a bit over the years. But when you're on that hormone deprivation therapy for many months, sometimes up to 2 years, testosterone production sometimes is not recovered for patients. So I think that the main domains, fertility, testosterone, prostate cancer, sexual health. So I guess urologists kind of play lots of roles there. And, sexual health is tied to a lot of things, testosterone. So low testosterone levels can be associated with erectile dysfunction, with a low libido. Getting that corrected can significantly impact both of those areas, but also, supplementation with medications that improve erectile function. So it's Viagra or Cialis, the kind of generic names for those, sildenafil, tadalafil, are very helpful. But there are many other options for medications. There are injectable medications. There are prosthetics that can be placed to improve sexual health. So yeah, urologists can offer a lot.
Yes, they can.
Mhm.
Go ahead, John.
I have another question. So, Dr. Lindsey, you mentioned
Mm.
cancer screening.
Yes.
How is that done, and
Mhm.
how does that play into just
Yeah.
regular care?
Yes. So I'll talk about it both from the vantage of the general population and for the CF population. So for the general population, we typically recommend screening sometime starting between age 45 and 50. So it doesn't have to be at 45. You can wait until 50 for the general population. And then that's just a blood test for the PSA. So PSA is prostate specific antigen, just a protein that the prostate makes. Victor was mentioning earlier, history of prostatitis. So when the prostate is inflamed, more of that protein is released. And so that can look like, this person has an elevated risk for prostate cancer, but it's just a protein. So big prostates, inflamed prostates can all elevate the PSA. But what we're looking for is prostate cancer, which can also make more of this protein, more of this PSA. So that's our best kind of biomarker that we have to date, and still the kind of recommended screening approach to that. And so, you start between 45 and 50, and then our guidelines recommend, roughly every 2 to 4 years after that, continuing to check that PSA. Historically, we were checking once annually, and now you're kind of developing a shared decision making protocols. So it kind of depends on individual patient risks, et cetera. So not necessarily needed annually. Annually is okay to do. And then, the big question is, who should be screened earlier? There are persons who should be screened earlier. So patients of, African American ancestry should be screened earlier. We know they have increased risk. So starting at age 40 for those patients. For patients who have certain mutations, so the BRCA1, BRCA2 mutations, those are the breast cancer gene mutations, tumor suppressor genes. We know that patients with a family history of that gene are at higher increased risk of developing prostate cancer. And then colon cancer, so we were talking about colon cancer there. Some colon cancer syndromes like Lynch syndrome, those patients should be screened for prostate cancer earlier, starting at age 40. And then anyone with a quote unquote strong family history, which there's no clear definition of what strong family history is, but examples are a brother or a father who was diagnosed with prostate cancer before age 60, any brother or father who died from prostate cancer or developed metastatic disease, also is a kind of strong family history. And then if there's two or more family members with some of these other cancers: breast cancer, ovarian cancer, colon cancer. So those patients should be screened earlier in that 40 to 45 window. And while we're talking about it and CF, and we mentioned a little bit earlier this colon cancer screening. It's not my domain specifically, but starting at age 40, colon cancer screening should be done for non-transplanted patients. And then, Chad, as you pointed out, it's recommended that within 2 years after your transplant, you should have had a colonoscopy or some sort of screening. So maybe Cologuard is adequate, but some sort of screening for that within 2 years of transplant, or starting at age 30 for anyone who's had a transplant.
Really good information.
Yeah.
We've been talking a lot about cancers and physical health. I want to talk about the effects on the mental health with low testosterone. Is there a correlation between the two? Are people with low testosterone, do they tend to struggle with their mental health more or anything like that?
Yes, it is something that is brought up all the time. There definitely, just from my own kind of anecdotal experience in clinic, there definitely does seem to be a connection there. It's not something that has been studied well enough for us to say definitively that getting treatment with testosterone therapy is going to improve, a mood disorder. But just from my own experience with patients, often patients are feeling much better, right? And if your sexual health is improved, if your muscle mass and strength are improved, your energy levels are improved, then that's probably going to impact your mood, right? So we can't say with strong evidence that this is modifying, mood disorders, but it seems very clear that it has a significant impact on those things.
That's very interesting because I
So,
agree. I think when, in general, when you're feeling better, you're going to start to feel better about yourself as well. So that's a
yep.
great,
Yeah.
great analogy there. Um, as the person ages, other than testosterone, are there any other hormone changes that happen inside males with CF, or just males in general, and then specifically with CF?
Yeah, it's a good question. There are other hormones that are impacted. So there's the hypothalamic pituitary gonadal axis. So brain and testes basically, where we have this kind of closed feedback system of our hormone levels. So all of those things can be affected with the low testosterone. Is kind of going back to this chronic disease burden of cystic fibrosis. We think that is what ultimately modifies it. So an example like anemia is something that is often present in the population, and that can be associated with low testosterone. Other outside of the main kind of testosterone pathway, thyroid function, et cetera, is going to kind of be outside my domain. So I would definitely refer back to primary care or your CF specialist for that. But the testosterone pathway has a huge impact for many of the biological systems.
I want to ask about studies. Obviously, we haven't had the aging CF population like we're experiencing now. Is there kind of a gap in research and studies to decide if there is a correlation between CF and some of these cancers, specifically like colorectal or prostate?
Yeah, it's a great question. So I think it's clear that colorectal cancer has increased in the population. In terms of studies specifically in the CF population, I imagine that there's a lack of data on the impact of CF and prostate cancer, just because this population hasn't lived as long as it has more recently. So definitely an area for continued study.
Okay, and then do you know specifically as far as high PSAs? Has there been any studies around that with CF people?
Yeah. So as far as the data that's available presently, no clear increased risk of prostate cancer. But as this population continues to age, I think it is something that we should continue to look at.
Um, just kind of want to open up the floor now, just to everybody, John and Victor. Do you have any questions you want to ask Dr. Lindsey, or is there anything that you'd like to see discussed?
I think that so that I'm interested in that in the prostate. So the prostate screening, and is PSA really the only kind of benchmark for screening for cancer, or is there any other types of screening that people can do other than just a PSA level?
Yeah. So PSA is kind of recommended as the first line screen for prostate cancer, but there are many more tests beyond that. So let's say you have your PSA measured and it's elevated. So our national guidelines, somewhere between PSA of 3 and 4 are kind of the cutoff for further investigation. So any PSA greater than 3 or 4 is worth additional evaluation. So then the first next step would be to repeat that PSA. That value can fluctuate for lots of different reasons. We were just talking about inflammation, prostatitis, et cetera. So maybe get that repeated in a couple of weeks, in a month, just to confirm the elevation. And if it's really elevated, and then we want to think about it in the context of a lot of other things. So, did you have, a urinary tract infection, or is there evidence of prostatitis? Because we may just want to, recheck again in 6 months. But to further diagnose from that PSA that's elevated, so you had the second test, you could go on to a biopsy. That's something that we've, kind of done for many years now. Going straight to biopsy. But more recently, we're doing things like imaging studies. So Victor, I think, mentioned the MRI. It's been very helpful in further risk stratifying patients. So we would give an MRI of the prostate, and then it gets a certain score. We call it PIRAS scoring, which goes from 1 to 5. And anyone with PIRAS score of a 4 or 5 are considered high risk. And then we would certainly think about biopsying for prostate cancer. There are other urinary tests that can have markers for prostate cancer. So there's the 4K test, PCA3. These are all molecules that we can detect in the urine, which can further help us gauge your risk for having prostate cancer on biopsy. So big picture there is that PSA is the first line still. It's the most sensitive test that we have. But then there are other newer developments that further help us decide who we're going to biopsy, when we want to biopsy, et cetera.
And then I was also wondering, thank you for that, by the way. I was also wondering, is there anything that could temporarily raise PSA, like a certain vitamin or food or diet
Yeah.
or sexual intercourse
Yes.
or anything like that, that would, like, if you go to the doctor and they're like, oh,
Yeah.
you're above that level, is there anything that could raise that?
Yes, classically, or certainly when I was in training, things that we worried about. So I was even doing a prostate exam. So there's the digital rectal exam to that urologists and primary care physicians as well perform to feel for areas on the prostate that might be concerning for prostate cancer. And historically, we would say don't get a PSA immediately after because of the way that can potentially raise your PSA levels. And the theory is good. I mean, we're pressing on the prostate, it releases that protein into the blood. And so maybe that modifies things. But I think the data more recently suggests that's not fluctuating the PSA numbers that dramatically. So that's not thought to be a modifier. And similarly with orgasm, recent orgasm is thought to potentially raise the PSA level significantly. But I think the impact of that as well is not something that is factored in as much in decision making. However, urinary tract infections, recent catheterization. So if you had to have a Foley catheter in your urethra to drain your bladder because you weren't able to empty your bladder, or maybe just had another procedure, either urologic or otherwise. Those things can transiently raise your PSA significantly. So those things are taken into context. But these smaller things, orgasm, bike riding, that PSA contribution isn't thought to be significant. But that's also why we check a second test. That first value that's elevated, we're going to check a second because of all these things that may or may not contribute to that PSA elevation.
Not that this is an issue at all in the CF community, but doesn't cigarette smoking increase the PSA a little bit?
That's a good question. It's not something that I think we are thinking about and understanding the PSA routinely in clinical practice, but certainly, cigarette smoking, as with many other cancers, is a risk factor for developing, bladder cancer, prostate cancer, et cetera. So, to that end, it should be considered. But for the actual PSA as a false elevation, I'm not so sure.
Great. Victor and John Kleven, I want to ask you guys about takeaways from today. What do you feel like is something that you may do or you may continue to do as a result of our conversation today?
Well, I was just going to say one thing is being inspired by Victor and seeing somebody kind of like what you were saying, Chad, somebody that is defying the odds and seems healthy and happy and living life with CF. So I feel like that's encouraging. I really am thankful for Dr. Lindsey and being able to have access to the knowledge that you have, and also to answer some of the questions that I have. And also, I feel like it's it's nice to not feel alone. in this, and in that when you're by yourself, resting from fatigue, that you're just not all by yourself, and that there are others out there that may have gone through the same things that I might be going through, and also that there's hope. So I feel like this has been very helpful for me.
Yeah, I would say I was really, really thankful for Dr. Lindsey and for this program in general. I think the information that's getting out there is very important. I think what we're going to see in the CF community is one of the big changes that occurred for me beginning in 1990. We were seeing that CF, which had been primarily a disease seen by pediatricians, that there were enough people who were adults with CF that we started seeing adult pulmonologists taking care of more and more patients with cystic fibrosis. And now probably the majority, there are more CF patients who are 18 or older than there are that are younger than 18. So the majority of CF patients are being taken care of by adult pulmonologists in the CF clinics. And we're now at this point in time, 2026, we are in the middle of another big shift. Whereas the CF community ages, there's going to be more and more individuals who are going to be seeing geriatricians, seeing the geriatric treating physicians. And these issues that we're talking about today, which are very important about sexual health and about testosterone levels, that's only a very small part of what we're going to see in the CF community as we continue to age and actually approach lifespans that are close to that of the general population.
That's the great thing. You're absolutely right. I mean, CF care has changed so much in the last 10 to 15 years. Um, None of this stuff is fun, but what an amazing time we live in where we have to start thinking about that now as CF patients instead of just thinking about our 16th birthday and will we make it there or not. So I agree. There's just so much awesome strides being made as we continue to live longer with CF. So it's been great. Well, Dr. Lindsey, John, Victor, thank you so much for joining us. I want to thank everybody for tuning in to Bold Enough to Ask. You can learn more about Breathe Strong CF by visiting breathestrongcf.org. And be sure to like and follow us and send us your questions to georgia@breathestrongcf.org. Special thanks to our producers, Georgia Brown and Catherine Russell, and our branding, which is done by Rachel Roggli. Thanks again for tuning in, and we'll see you next time. Hey everyone, this podcast is for educational purposes only and is not a substitute for professional medical advice. Always consult your physician or qualified healthcare provider with questions about your health.